Welcome back to the Virtual Leadership Alliance National Symposium. And if you're just joining us, hello there. I am Dr. Madeva Gee, the Executive Director of the Leadership Alliance and an Associate Professor of the Practice of Behavioral Sciences at Brown University. The theme of our symposium is Scholars United, Dismantling Injustice. And our keynote speaker for this plenary session is doing just that. And I have the privilege to introduce to you, although I believe that many of you may know Dr. Ashish Jha by watching the various media outlets. I know him as my dean at the School of Public Health at Brown University. His bio is in the program guide, so I will just touch on some highlights of his distinguished career. Dr. Jha received his bachelor's degree in economics at Columbia University and then went on to get his MD from Harvard Medical School. After doing a residency at the University of California, San Francisco, he also obtained his Master of Public Health at the Harvard T.H. Chan School of Public Health. He's had a distinguished academic career at Harvard, and we are so happy that he came south to join us at Brown University as Dean of the School of Public Health. Dr. Jha, we want to thank you for sharing your expertise on the front lines of the COVID-19 response and for joining us this afternoon. We're looking forward to your comments on using science to combat racism during the COVID-19 pandemic. Welcome.
Madeva, thank you. And everybody, thanks so much for having me here and for joining this virtual webinar. I know virtual seminars and webinars can be a little tough, but I'm hoping that what I will do is I'm going to try to chat with all of you for about 25, 30 minutes. And I am going to talk about this pandemic and what it has taught us about structural racism, inequities in our society, and about how we use science and evidence and data to understand the issues and to confront and challenge these issues. And I'm going to, as I said, speak to you for about 25 minutes. And then my hope is we turn this into a discussion where you all will have lots of questions for me, which I will answer to the best of my ability. So let's take a look at where we are in the pandemic right now. COVID-19 pandemic is the biggest, worst health crisis the world has faced in 100 years. I would argue the biggest crisis of any kind, probably since World War II. Just awful what's been happening around the world. When you look in the United States, more than 600,000 Americans have died. Lots of families have been really harmed by this. Tens of millions of Americans have gotten infected. So on one level, you can look at this and say, boy, it's been awful for everybody. It has. And you can say, boy, we really are all in this together, and we are. And then you may be tempted to say that, you know, pandemics and COVID-19 affects all of us equally. And it doesn't. It doesn't affect all of us equally. It has affected some people and some groups much more than others. And I want to tell you a little bit of a story about that, and a little bit of a story of how we, I would argue, as a country came to realize last April to May that this pandemic wasn't affecting everybody equally. That it was in fact affecting some communities and some people much more than others. And as we came to realize that, I want to talk about how science and data, if you use it effectively, can teach you what the underlying issues are. And then if you are willing to read history and understand the history of our country, you get a much richer picture of why the disproportionate effect, the fact that COVID has basically had this very substantial effect on communities of color, particularly Black communities, African-American communities, that this should have been actually expected. And that is a story that I think we should start just unpacking. And my hope is that it's a way to think about the fact that science, evidence, data, these are just tools, right? They're not some difficult, crazy things, and they're not ends unto themselves. They are tools. And if we get really good at using these tools, we can use them for things we care about, such as dismantling injustice, such as fighting against systemic racism, such as fighting against the deep inequities that have plagued our society, our country, really since its founding. So let's talk a little bit about what has happened over the last year. In late April of 2020, about a little over a year ago, we started seeing the first set of data on how the pandemic was going, who was dying from the pandemic, based on race and ethnicity. And at that time, it was primarily based on race, and it was primarily looking at what was happening in cities like Detroit, like New York, some other places, Seattle, and New Orleans. And what we were seeing was this very large effect, and that if you were Black, you were far more likely to be dying of this pandemic than if you were white. And then when people looked at infection numbers didn't actually look that different. A little worse, but not that different. And for a little while, it was a puzzle. People said, well, how could this be? Why would it be that African Americans were not getting necessarily infected at much higher rates, but they were dying at much higher rates? And people had all sorts of theories. And anytime you start getting into race stuff, you always know that you get the crackpots who start coming up with some crazy theories. But that was one of the first moments when many of us, looking at the data, said, oh, hold on a second. Let's examine that data a bit more carefully. Let's dig in a bit more carefully. And we started looking at something called test positivity rates. Now, you may say, I don't know what test positivity rates are, and that's fine. But if you think about, how do you know that somebody has an infection? How do you know? Well, you know somebody has an infection if you've gotten a test for that infection. Well, back in late April of last year, we didn't have a lot of tests around. And what we knew was that we weren't testing everybody who was infected. And when we started looking at who was actually getting the tests, we realized pretty quickly that the problem was that the tests were being done predominantly in wealthier communities, in whiter communities, and that there was actually far less testing happening in African-American communities in these cities. And that was the explanation for why infection numbers didn't actually look that different. Insight number one, right, is that where you do testing, where you set up testing sites, I'm going to talk a little bit more about that in a second, actually affects what kind of data you have. So you can say, wow, it doesn't look like there's a big difference in infection numbers between Blacks and whites. It turned out that the actual infection numbers were dramatically different. It's just that we weren't testing people of color in the same way. And that was what was going on. Again, look at the data, dig in one level underneath, try to understand what's going on, and you get a very different insight. Then many of us started trying to figure out, well, what's going on with testing? Where are these testing sites being set up? And what we very quickly learned was that people who were designing the testing sites, many of them were setting up drive-through centers. But what if you don't have a car? What if you live in a neighborhood where nobody has a car? That all of a sudden, those drive-through centers don't accommodate people who just walk up and want to get a test. And so you had people getting on a bus, showing up to these testing sites and wanting to get a test because they felt terrible and couldn't get one. And so drive-through centers, drive-through testing was set up to make sure, I mean, it wasn't done purposefully, but it was designed to ensure that people who don't have cars are far less likely to be able to get tested. So the point is that good intentions, people design testing as a way to try to capture who's infected, but the way we did it ended up disproportionately harming African-American communities. And therefore, it looked like the infection numbers in those communities were actually much, much lower than they were. We're going to come back to solutions in a minute. The second set of places where, again, and part of what I'm doing is laying out stories and telling you how, if you understand data, you pretty quickly figure out where the policymakers are getting something wrong. We saw these, as I said, huge gaps in deaths, large numbers of much, much higher rates of deaths among African Americans. By the way, that's in the first phase. In the later phases of the pandemic, we see this for Latinos, we see this for Native Americans. So this is not just an issue of African Americans, but in the early days, the primary data were really coming out on African Americans compared to white Americans. And as you looked at the death numbers, these dramatic differences in deaths, then there were surveys done. Who's dying in the hospitals? And what we found was that it was predominantly people, elderly people, who had actually been staying home. And so then the response from policymakers was, oh, these people have chronic, excuse me, these people have chronic diseases, they have high blood pressure, diabetes, they have terrible diet. Again, very classic. We love to blame patients. We love to blame the victims. And that was the explanation, that maybe the reason African Americans are dying at much higher rates is because They have all of these chronic diseases. Well, there are higher rates of chronic diseases. That actually wasn't what was going on. There were two sets of things going on that, again, it took data analysis and it took understanding history to unpack and really understand. So the first thing was to understand that people don't go to the same hospital, that white Americans end up in different hospitals than African Americans. Actually, there's very good data, including a lot of work that we have done, that shows that our healthcare system is incredibly segregated. That it turns out that even though officially everybody can go to any hospital, that certain hospitals are in certain neighborhoods, and certain hospitals have a historical relationship with certain communities. And that means that in some communities, all the white patients are in one set of hospitals, and all the African American patients are in a different set of hospitals. And those hospitals are not the same. And they don't have the same set of resources. They don't have the same amount of, they don't get the same amount of money from the government. And almost always, the hospitals that disproportionately care for African American patients tend to be less wealthy, and they tend to get less reimbursements. Well, what does that mean in a pandemic? Well, what it means is that when there is a surge of new infections, surge of hospitalizations, lots of people in the hospital, a poorer hospital is going to have a harder time making sure they have all the equipment they need. They're going to have a harder time making sure that ICUs are well staffed. They're going to have a harder time making sure they have enough doctors and nurses on staff to take care of everybody. And all of a sudden you start realizing that this wasn't about individual people's habit as much as we love to blame patients for their problems. This was really a systemic issue, that the way we had structured our healthcare system meant that white patients were ending up in different institutions, and those institutions had a lot more resources than the institutions where Black Americans were getting care. You needed to understand the data to understand that. You needed to also understand history to understand that, right? Because historically, we know that healthcare has been very, very segregated, and therefore we could have predicted that this was going to happen. And if you have hospitals that have fewer resources, they're going to do a worse job taking care of people. And there's plenty of evidence and plenty of data that hospitals that disproportionately care for African Americans tend to have worse quality care for everybody because they just have fewer resources and fewer capabilities. We know that from before the pandemic. The pandemic made that very, very clear. The other reason we found that there were these large effects in older Americans dying at much, much higher rates if you were African American compared to white is that African American communities, they tend to have many more multi-generational households. What do I mean multi-generational households? Multi-generational households are what they sound like, right? Where people of multiple generations, kids, the parents, and the grandparents all live in one household. We can come back to why that is, but that is a case. And what we also know is that in those multi-generational households, African Americans are much more likely to be essential workers. So the parent with a little kid, that parent is much more likely to be an essential worker. So when things shut down last March and April because of the pandemic, some people continued to work because they had to continue to work. They were the essential workers, the grocery store workers, the people who worked in public transit, the people who worked in hospitals. Those essential workers far more likely to be poorer, far more likely to be people of color, and then of course, much more likely to live in multi-generational households. They pick up the infection because they have to go out to work. They live in a multi-generational household. They come home, they end up infecting their elderly parents, and those elderly parents end up getting sick and dying. That was the mechanism that nobody understood. And again, policymakers in all of this stuff immediately go to blaming the people themselves. But you have to understand the historical context for why that is. And I'm going to talk a little bit more about that. And you have to understand the data of what we're seeing. And one of the things that took many of us who spent our lives thinking about data was examining the data. So for instance, there was a governor who I will not mention who stood up in a press conference and said, you know, the reason all these elderly African Americans are dying is because they have more high blood pressure and diabetes and because they have bad health habits. And a lot of us just looked and shook our heads and said, no, it has nothing to do with that. That is not what's going on. It's because their kids are essential workers. They live in multi-generational households. And by the way, you've set up testing sites in places where these people can't get tested. So people don't know that they're infected. And that's why the virus is spreading in much, much higher levels. But how do you push back? And and the way you push back is by gathering that data. And I'm going to come back to that last point in a second. Let me say one last thing that I think was fundamental as a contribution to why we saw these very, very large disparities. And that is really a term that you've heard before, that people use sometimes in vague ways, and I'm going to try to give you my way of thinking about it, and that is systemic racism. So a lot of people talk about systemic racism. People have different definitions of it. I am not the world's expert on systemic racism, but I will say the way I have thought about systemic racism is that you have these long-standing policies in our country that are racially based, that end up having this very negative, disproportionately negative effect on people of color, right? So what are these kinds of policies? Zoning laws that we have in cities, zoning laws about where housing is set up, where highways are put in, ways cities are planned. It's not random. And it is not random that bus depots where buses idle for hours are often located in communities of color. It is not random that highways are put in through communities of color, and so those places tend to have lower housing value. It is not random that multi-generational households and the kinds of housing in those communities of color are different. Those are policies that America has made, and those are the policies that essentially created the backdrop and the situation that led to this very disproportionate effect of the pandemic. All right, so all of that got uncovered, I would argue, kind of April through June. And we all said this, so how did it become uncovered? Again, using evidence, using data, we were able to understand these problems much, much better. So what did we do? What were the solutions that were implemented? So I'm going to talk a little bit about the good news, and then we'll talk about how we've gotten stuck again as we've been thinking about the vaccine rollout. And then I will stop after that and see what questions and comments you have. So what did we do to make improvements? First is we started setting up testing sites in different places. We started working with community-based organizations, started setting up testing sites in places and didn't have them as drive-throughs, right? Made it much, much easier. By the way, one of the key things on testing is having evening and weekend hours. You want people to go get tested, but if you're only open 9 to 5, people who have jobs from 9 to 5 can't show up, right? So part of it is like making it accessible for people. That was one set of things. Second is there was a real effort to try to figure out how do we help the hospitals that disproportionately care for minority patients, for people of color, and how do we help those hospitals get better so that they can actually do a better job? How do we surge more staffing? How do we surge more resources, more protective equipment? There were a lot of efforts, not everywhere in the country, but a lot of efforts, again, in that kind of catch-up mode to try to address it. And what we saw, thankfully, I would say, as we got into the summer months and as we got into the fall months, is the very, very large gap that we were seeing in the spring narrowed. And that's good, because what it tells you is that if you understand the underlying mechanisms, if you go beyond the headline numbers and you don't accept what I think are often very superficial and ignorant explanations, but dig down below and really understand what's going on, then you have a pathway for moving forward and for coming up with solutions that are going to actually reduce inequities, reduce injustice, and make those gaps smaller over time. And a lot of that happened, and I think a lot of that was very, very important and powerful. Okay, so let's now fast forward to what has been going on with the vaccine rollout. So all of you probably know, we've been rolling out the vaccine, the COVID-19 vaccine, across the country, and as it was getting going, you heard from the Biden administration, you heard from the CDC, you heard from everybody that we know this pandemic has disproportionately affected communities of color, and we are not going to let those inequities show up again in the way we do vaccine rollout. That was the promise. Great promise. So what's actually happened? What has actually happened is that the vaccine rollout has been pretty inequitable. We see large gaps in who's gotten vaccinated. And some of it is, I wouldn't say understandable, but some of it was predictable, right? Some of it was predictable in some of the strategies we use. For instance, we focus on essential healthcare workers first. Well, a lot of those essential frontline healthcare workers are white or and fewer number of people of color. But one of the things that many of us argued for is that it's not just about doctors and nurses, where we have some diversity, but not enough. We also have to make sure we're vaccinating other frontline workers, people who work in hospitals, people who are front-facing and interact with patients. Some of that happened, some of that did not. But as the vaccine rollout kind of continued into the spring and summer, we now find ourselves with about a third of the country, a third of adults who are eligible, not yet vaccinated at all. And then when you look at who is not vaccinated, you see pretty substantial gaps based on race. So I want to spend a few minutes talking about that and why, again, instead of just looking at that and there's a temptation to just blame the unvaccinated, it's very, very important to understand why. Why are people of color less likely to be vaccinated? And what can we do to begin to address it? Because simplistic, ignorant answers of just saying, well, these people are anti-vax, first, not true, second, not helpful. We've got to take on a very different strategy. So as people have started digging in, gathering evidence, gathering data, what we are learning is that for a lot of people, it's not easy to get vaccinated. Now you may say, well, what do you mean? Vaccines are available everywhere. They are available everywhere. But if you're one of those essential workers who can't take time off, you've heard that after you get your vaccine shot, a lot of people feel pretty lousy for 24 hours. And they think, well, I can't afford to have a day off. What do I do? And that becomes a barrier. So it's not the, I can't get a vaccine, it's I can't take a day off, or I can't take a day off of work, or I can't take a day off. I have young kids at home and I don't have a babysitter, I don't have somebody to take care of them. Those are things that affect certain communities and certain people more than others. And we have not really come up with a strategy for how to manage that. That's one set of barriers that we should have predicted, we should have seen coming. We have not done enough on this, and that's one of the reasons we see this vaccine gap. Another reason we see the vaccine gap is what I would argue is long-standing historical mistrust. Now, again, this is not just about gathering evidence and data, it's also about knowing your history. The history of healthcare in America is not a glorious one when it comes to thinking about racial equity. It's actually one of the many tragedies of kind of the racial injustice of our country, is that the healthcare system has perpetuated that racial injustice, that the healthcare system has mistreated, maltreated African Americans at much, much higher rates in very different ways. I've already talked a little bit about segregation in hospitals, but plenty of data around the way Black Americans have been undertreated for pain, undertreated for their cardiovascular disease, undertreated for cancer. So there is a lot of mistrust, not among everybody, but among certain segments of the African American community. A lot of mistrust of a healthcare system that has not done right by them. And one of the things I often say is if you do not trust the health system because it has not treated you well, and then one day somebody shows up that you've never met before and says, hey, you want a vaccine? Don't be surprised if people don't jump at it. So there is really, really important work to be done. And you got to work with partners that people trust to get across and deal with that mistrust, to help people get more comfortable. And calling people anti-vaccine or calling people hesitant isn't helpful. It's helping all of us understand, why are people not ready to get vaccinated yet? And what can we do to help them get ready? That is important, hard work that is just barely getting going. I wish we had begun that work 6 months ago when we first had these vaccines, because it's not work you can do overnight. But I do think that if we do that work, we are going to start seeing more vaccine equity. We are going to start seeing higher levels of vaccinations in the African-American community. And I keep talking about African-American community. A lot of the lessons, they're a bit different, but a lot of these lessons are also true for the Latino community, for Native Americans. So this is not meant to be exclusively, but that's where a lot of our data is. So let me finish off by saying, maybe just making a couple of kind of summary points. This pandemic has not affected all of us equally. It has affected communities of color, people of color, much, much harder. many more people infected, many more people hospitalized, more people have died. When it comes to vaccines, we have not distributed vaccines equitably. People of color are far less likely to be vaccinated. And each of those phenomena, when America has become aware of it, when we first found out that death numbers were much higher for African Americans, the policy response, the media response is always simple, and it's blamey, and it's wrong, right? It always begins by blaming the victim. It begins by blaming the community that's been harmed. It begins by saying, well, it's their fault because of X, Y, and Z. And my question to all of you, it's what's your job in that context? Well, you can push back and say that's not true, but you can do better. You can do better by showing up with data. You can do better by understanding the history. You can do better by saying the reason infection numbers are not that much higher, but death numbers are, because you're testing in the wrong places. And therefore, you're not capturing most of the infections that are going on. You can say the death numbers are higher, not because people of color somehow don't take care of themselves. That's nonsense. It's because the hospitals they go to are different. And we have data on that. We have evidence on that. And that's how you begin to push back. And when you begin to push back, you can actually start identifying solutions that move the needle. So instead of just saying this is wrong and we will not blame people who are actually the victim of injustice, you can start laying out a groundwork for here's how we're going to do it better. We're going to put testing in different sites. We're going to surge resources to different hospitals. We are going to think about how we protect essential workers. There's a whole set of policies that are necessary and actions that are necessary, but they have to be driven by evidence and data. This is why when Dr. Gee asked me to come speak to all of you and told me about the theme of this session and of this around scholars united dismantling injustice, felt like this was a particularly important moment to talk about how scholars, evidence, people who know how to use data are in fact, I think, best poised to dismantle justice, because they can go beyond rhetoric. They can go beyond just saying this is wrong. They can explain why it's wrong, and they can explain why, and we can explain what needs to be done to make it right. So the pandemic isn't over. We still have a lot of work to do. The equity challenge in front of us is still quite substantial. And I have focused, by the way, purely on one group of Americans and the inequities they have faced. And I have not even talked about the global inequities that exist. I'm happy to get into any and all of that, but I wanted to use that as a case example to say, if you want to make a difference, arm yourself with data, arm yourself with facts, learn how to use evidence, get the tools you need, because let me assure you that other people will use data and tools to perpetuate injustice. And if you want to fight against it, you want to be well armed and well prepared. Thank you, Madeva, for having me here, and let me turn it back over to you.
Thank you so much. That was so helpful. That was so powerful. It was so important for us to take the time to reflect on what we've all been experiencing, but it's just so great to hear it from your perspective, being on the front lines of that. And we're starting to get questions roll in, but I'm going to take the privilege of the moderator and ask a couple of questions, because I really liked how you talked about in terms of when the data were coming out, people weren't asking the right questions. And I was just talking about that earlier in my comments to the students. And I remember as they were talking about the data, it was all aggregated. And even then I was wondering what is happening at the different population level. And so I was wondering, if there were sort of a multidisciplinary panel at the beginning, sort of really being able to think about those issues and focus on those issues, would we be in a different place now? And could you comment on sort of like the importance of having that multidisciplinarity at the table at the beginning of these very big complex problems, so that we don't have to go through it to get the lessons learned. We can actually understand them as we're going along.
Yeah, no, it is a fabulous question. And the way, I know a lot of the public health leaders in the United States, a lot of people who run major health departments. They're good folks. They really are. They're good people. They want to do right by everybody. They care about racial equity. They got a lot of stuff wrong. So then the question is why? Because here's the thing, right? It's easy to say, well, people who are racist, people who are ignorant, people who don't care, they're getting stuff wrong. Well, absolutely. But it's actually a lot of good people who are smart, who are thoughtful, who are getting it wrong. And that started getting me thinking, why? Why did so many good people get this wrong? Why didn't they see it coming? Why didn't they understand? And why weren't they asking the questions you're asking all of us to ask? And I think it's because of, and again, no offense to them, they're terrific people, but it's about their lived experience, what communities they're from, how they understand the world. And this actually, to me, is the most important, my most important kind of insight into this, is that there weren't the right people sitting around the table. This is your question. The people who needed to be sitting around that table were people who were from those communities. We needed more of those people. We need people who understood what living in a multi-generational household is actually like, who understood that you put up a drive-through testing center, you're going to have certain people who just can't drive through.
Right.
It's not going to work. Seems like drive-through testing center sounds great. Let's do that for everybody. No. You got to, and it's subtle stuff. And sometimes it seems so obvious in retrospect. There are hundreds of things like that. So, one of the things that you and I have spoken about, Madeva, but I believe very, very strongly is we're not going to fix this until we get different people around the table, until we get a leadership of public health that looks different, that has had different set of experiences, that has functioned differently. Then it's not about just making people better people. And there are a lot of very good people trying to do this. We just need different people around the table.
Yeah, that's great. And actually, there was a student who has a question that's very similar to mine. The student is a computer engineer at the University of Iowa, and said, being someone outside of the medical field, what is one piece of advice that you have for people like me to positively impact health equity in our communities?
Oh, it's a really good question. I talked a lot about data, and I'm going to, particularly because you are a computer engineering student and you understand data. A lot of the very, very best data for this pandemic came not from the healthcare system, not from public health experts. They actually came from outsiders, people who said, "What do you mean we don't have data on by race and ethnicity? Let's figure out how to get it."
Right.
And used very different tools to begin to help public health. So, health is one of those things that you don't just want health experts working on it. You actually want people who are computer scientists, who are engineers, who are political scientists and other types, and economists. There's a lot you can do. And again, for the computer engineer in the crowd, I'm going to say use your skills as that to bring more data and to bring more new ways of collecting and analyzing data to the conversation.
Yeah, and I also wanted to pick up on that theme about using data, right, to really think about what we want to do. But there's also a way we have to be able to translate that data, right? And we're in a moment now where we have a lot of data, and there's still a lot of vaccine hesitancy. So I guess one question that I have is, how can you translate that data to those so that they are more, able to say, I see the benefit of this? What are some strategies that we should be thinking about? Because I think each of us has a part to play in this, and really think about how can we talk to different communities from our lived perspectives and be part of, not just saying it's all for people in the public health, but that we each have a chance to translate what the data mean to various communities so that we are able to get past this.
Yeah, no, it's a really good question. And I would say, at the end of the day, nobody at the end of the day really changes behavior based on data alone. That data has to have meaning. It has to have some value in our lives. It's got to be about something we care about, something we find meaningful. And so our job is to translate the data into something that matters to people. And one of the things I try to do, I'm not saying I'm the best at this, but one of the things I try to do is I try to personalize it and talk about my own behavior. So why have I gotten vaccinated? Partly to protect me, but also to protect my elderly parents who I care about, right? Of course I care about them. They're my elderly parents. And so I say, like the data says that if I'm vaccinated, I'm much less likely to transmit it to them. And that is a really, really important part of why I have gotten vaccinated. Now I'm taking data and I've translated into an action, into something that is meaningful to me. And I bet for a lot of other people, that is also meaningful, the idea of protecting others. So we always have to find opportunities to say, what does the data tell us about something we care about? And how do we connect these things in a way that feels personal to people? Because nobody's going to get vaccinated because its efficacy is 85, 90%. You get vaccinated because you want to protect yourself. You want to protect your family. You want to protect your kids, things that matter to you.
Yeah, that's great. And I feel as though it's given us a script that we can adapt to use as we talk about the benefits of the vaccines. Okay, so now I'm going to get into the student questions. All right, so there's a student who says, who and what have you found to be particularly useful for encouraging those who are vaccine hesitant? So a little bit on the same lines of the previous.
Yeah, it's a great question. So there's all sorts of different people who I think are really influential in encouraging people. I think, again, I sort of alluded to this, but it's who do you trust, right? So who do people trust? Maybe you trust some guy, some doctor you see on TV, maybe. You probably trust your doctor if you have the right kind of relationship. We saw in Chelsea, Massachusetts. So Chelsea's a neighborhood with a lot of poor folks, a lot of people of color, really, really hit hard in the pandemic. Has done a fabulous job in getting people vaccinated. How did that happen? It happened, there are a couple of different parts of it, but one of the major reasons is there was a community-based organization in Chelsea that throughout the pandemic fed people. That in the darkest days of the pandemic, where things were really horrible, things were shut down, it was hard to get food, you could go to this place and pick up food for yourself and your family. And it was an organization that people had known forever. Well, February, March comes around of this year. They started also offering vaccines. They said, come for the food, stay for the shot, go home. And now what happens is people trust these guys because they have been there at the darkest moments. They have been there taking care of that community. If that place is offering vaccines, it feels very different than some guy you've never met before showing up and saying, hey, get a vaccine. Right? So it's about trust. It's about relationships. It's about who do you know and how well do you know them? Those things really make an enormous difference. Sometimes that's a religious leader. Sometimes it's a political leader. Sometimes it's a public health leader. Sometimes it's your community-based organization that gives out food to people who are struggling during difficult times.
Yeah, that's great. So another question from a student is asking about potential mandating vaccine requirements. And this is a hot topic. And so he asked, do you think it is important to mandate vaccine requirements for an unapproved vaccine?
Yeah, that's a really good question. And it's an interesting way to ask it because is it an unapproved? It's authorized by the FDA, but it does not have full approval. You're absolutely right. So I think, first of all, the FDA is making a mistake by not giving it full approval. And I think they will give it full approval probably in the next month or two. Second is what I say to folks is, what do you care about? I mean, what you care about in terms of these vaccines is you want to make sure they're well studied, they're well tested, they've been given to lots of people. Well, there is no drug, no medicine, no vaccine, no test that has been tested and examined in more people than these vaccines. These vaccines are so incredibly well studied at this point. We've given them to hundreds of millions of Americans and billions of people around the world. There is no vaccine or treatment that I know of that has that much. And the data is really, really good. So I think that is giving a lot of people confidence to say, yeah, we can mandate these vaccines. So where we work, Deva, right, at Brown University, we have mandated vaccines. We've said to everybody, you want to come work here, you got to be fully vaccinated. I feel very comfortable doing that. The FDA will catch up. I think the FDA is coming on this soon enough. They're just being a little slow because sometimes it can be a bit bureaucratic. But the truth is that there is so much evidence and so much science that I think lots of organizations feel very comfortable going ahead and doing the mandate.
Yeah. this next question is actually something similar to what I was thinking about as you were making your remarks. You were talking about, having people understand other people's situations. And the two words that came to mind was cultural competency. and so, how does that fit within the training? Because, this is something that needs to happen. And so this next question is sort of picks up on that. And is the history of systemic racism in healthcare taught in medical schools or graduate medical programs? And if not, what do you think teaching it would change? So to give them that historical context, to give them that cultural competency, to be able to think differently in these really important healthcare situations.
Yeah, it's a great question, Clarence, that I'm gonna, just looking at the chat here, thank you for asking that. And the short answer is not taught enough, or very little actually, in terms of the history of systemic racism in healthcare. And why would it even help? You say, well, that's history, why do I care? I'll tell you why you care and why it would be so helpful. It would actually help us understand the moment we're in. It would understand, if you are a medical student, you're doing a rotation at Boston City Hospital in Boston, you would understand why that hospital is different in some ways than a Brigham and Women's. Two great hospitals, but one was a city hospital that historically took care of the poor, still does. And understanding the history of hospital segregation, for instance. And it was only in the early 1960s that hospitals no longer were allowed to be segregated. Until then, you literally had hospitals that would not take care of Black people. Just wouldn't do it. Now that's not legal anymore, thank goodness. But as you might imagine, even if it's not legal, there are still hospitals that do lots of things that make it harder for certain types of people to get care there, in terms of what insurance you accept or how you do things. So there are lots of ways that those inequities continue. These are not just historical exercises. But I think the historical understanding would make a major difference in helping people understand what they're seeing in front of them, why they see certain patients with certain types of conditions showing up to the emergency department day after day, while we don't see that in other places. And when you don't have that understanding, then you jump to stereotypes. Then you jump to, and you're much more susceptible to simplistic and ignorant explanations, which people love giving. So that's why you got to educate yourself, because you want to make yourself not susceptible to that nonsense, right? And you want to have a clear understanding of what's going on.
And that has actually happened to me I guess a year ago, I went to the doctor's office for my physical and I was rushed. So I was a little stressed, and they took my blood pressure, and the physician made a comment about, well, you may have high blood pressure. And it was like, I have no history of high blood pressure. And so when they made that comment, I was thinking, that's, why would you assume, are you assuming because of who I am, what I look like, where I live? So I think it really speaks to this next question about the next step what is the next step towards a future without bias in the healthcare system?
Well,
it's a big question.
It's a big question. I mean, in some ways, arguably, it's one of the most important questions of all, right? Like, how do we get there? But I think it's also a question that doesn't have a simple answer. If we really want a healthcare system that is equitable, if we really want a healthcare system that lessens the gaps in our society, not widens them, as you might imagine, there isn't a single answer. It's got to be a multi-pronged approach. We need a multifaceted approach. There are ways in which the healthcare system has made real progress, I think, in the last few years, but particularly in the last year. And one of the few silver linings of this horrible pandemic is I actually think healthcare leaders are much more open to acknowledging the way systemic racism plays out in healthcare. Mm-hmm. That is not a conversation we could have 5-10 years ago. People would just bristle at that. Now we're able to talk about it openly. And that's a start. Look, talking about it openly is not a solution, but it's certainly a start. There are real problems, though, in our health system. For instance, the number of African-American men who are physicians in 2021 is about the same number as it was in 1980. Like, what is that about? And it's a tiny number.
If it was great back in 1980, then we'd say, okay, fine, it's great then, back great now. It's not. It was terrible.
Yeah.
Still the same. Unacceptable. How have we not made progress on this in the last 40 years? So there are areas where colleges and medical schools have to do a very different job of thinking about these issues and saying what role do we have to play to begin to solve these things. And then there's some stuff we've already talked about, teaching people about the historical context in which they're going to be providing care. That's really important, making sure that there's still lots of little features of the healthcare system. It still shows up that when we, for instance, there's a little blood test called creatinine, which is a kidney function test. We still look at that, and the way you interpret it is different for whites and blacks. And then you go back and you dig into what's the history behind that. And again, not super scientifically based. There's a lot of stuff like that that essentially perpetuates stereotypes and really makes people think that a lot of the stuff that's social constructs is somehow based in biology. Yeah. We have got to continue working on eliminating those things from the healthcare system because they essentially feed a narrative of inequity that's, I think, ultimately very harmful. So a lot of work to do. I hope you all go into medicine so that we can fix it together.
Academic medicine and PhD programs.
And PhD programs, absolutely. Sorry. Or PhD programs, or do whatever you want to do.
Yeah, exactly.
Yeah, no, I'm not trying to recruit everybody into medicine, but if you want to, do it.
Exactly. Well, the next question asks, do you believe having more diversity in the medical and research industry would make people of color more likely to seek medical help, including vaccination? And I think we kind of touched on that.
A little bit, yeah. I do. I do. I think there's actually very good evidence that a more diverse workforce would be helpful in building trust. That well, there are two parts of it in my mind. One is it's pretty good data that African American patients feel a greater level of trust and comfort and willingness to accept recommendations from African American physicians. So that's really important unto itself. But the truth is that we've all got to get better at earning trust. So while diversity is absolutely essential, in some ways I would argue it's not enough.
Right.
And we've all got to get better at earning trust of people, and particularly people who've been historically treated, and not even just historically, even current day, treated badly by the health system.
Right. And we've talked a lot about sort of racial diversity. And the next question is actually from my colleague, who's the chair of the Symposium Planning Committee, Dr. Brunson, who is asking about class and says, to what extent has class been a factor associated with who has chosen to receive a vaccination shot?
Yeah, it's a really good question. So here's what we know from data. Certainly education is a huge predictor. People who are college graduates, much higher rates of vaccinations than people who did not graduate high school. So the survey data doesn't look at, class is sort of a funny term because it could mean several different things, a mix of education and income, and but to the extent that education is a proxy for class, there's no doubt about it that education is a major predictor of who's gotten vaccinated and who has not.
Yeah, great. So I'm scrolling and there's a really interesting question that asks about the different communities, African American, Hispanic, Latino, and Native American communities. Will the other variants affect these communities even more? And also, how can this data influence others to get vaccinated, as many people are hesitant to get the vaccine?
Talking about variants of the virus, like the Delta variant? Yeah, I have to tell you, I'm very, very worried about this. The Delta variant is really bad. It is by far the worst variant of this virus we have seen throughout the whole pandemic. And to be perfectly honest, much worse than anything I thought we would see. So what does that mean? It means that if you are unvaccinated in America, this is a very, very dangerous time. It means that you have a very high risk of getting infected, a very high risk of getting sick. And so we've already talked about communities with lower vaccination rates. We've talked about individuals with lower vaccination rates. So I worry a lot that in the weeks and months ahead, as Delta surge really continues, and as we track who's getting infected, we're going to see a lot of people of color get infected and get very, very sick. So that continues to worry me a lot.
Yeah, and on that note, there's another question very similar to this, is how do we gear our communities with the tools needed to prevent infections leading into the winter? I personally am still wearing masks when I go into indoor places where I don't know if people are vaccinated. So is it as simple as that?
No, I mean, it's that helps. And the CDC just came out with some recommendations around that, updating its guidance just a couple of days ago that said that if you're in a high transmission area, a lot of infections happening, you should be wearing a mask indoors if you're fully vaccinated. And the reason is because you can have a breakthrough infection, you can spread it to others, and those are good reasons to continue wearing a mask indoors. I thought the CDC guidance on that was perfectly reasonable and fine. The problem is it's not just indoor mask wearing. I mean, a lot of the spread happens, for instance, in indoor dining, in bars and restaurants, right? And that happens in two ways. I mean, certainly happens for people who are there because they're eating and drinking, and therefore, by definition, not wearing a mask while they're eating and drinking. And that causes a lot of spread. But there are also people who work there, and they may be wearing a mask, but in a high transmission area, that mask may not be good enough. And so the essential workers, the bus boys and the waiters and the people working behind the bar, they're still at pretty substantial risk, especially if they have not gotten vaccinated. So avoiding large indoor gatherings, especially in high transmission areas, probably a good idea for the next couple of months. And then we can't give up on testing. I mean, the good news is life is very different in July of 2021 than it was in July of 2020. We have so much testing available. Testing is available everywhere. And so at the slightest symptoms, we got to get people tested. And we got to make sure that people, if they're infected, are self-isolating. And then, of course, we got to do everything we can to get people vaccinated.
Great. This question is a little different, and I really like it. It's with representation lacking in the scientific community, how do you advise underrepresented students to believe in their own voices?
Oh, boy. It's a great question. And I have to tell you, I want to ask you this question because I feel like I turn to you for at moments like this. I would actually love it if you would say something, but I understand it.
Yeah, no, I'm happy to. I'm happy to.
Yeah, but it is a really hard question. And what I would say is it is obviously much harder when you don't have role models. When you don't have people who've had the same lived experience. But there are a lot of us who've kind of made it, who are part of the inner circle, who care deeply about this. And we want to try to be as supportive and helpful as being mentors. Look, the truth is science is an apprenticeship and mentorship thing. Large part of the reason I have had any success in this is I have had great mentors who believed in me. And I can never pay them back, right? Because they've had great careers. And so the only way I pay them back is by trying to pay it forward. So many of us are trying, but I would say to people who look at the scientific community and say, I don't see a lot of people who look like me. I don't see a lot of people who have the courage, know that there are a lot of us out there who want to be supportive, and then you can become the role model for the next generation. It definitely takes more courage. It definitely takes harder work. And I am sorry that that's where we are as a country, and I wish we weren't there. But if you're willing to take that courageous step, there are a lot of us who are there trying to be helpful and supportive.
Yeah, no, I would agree 200%. That's exactly what I was going to say. I was going to say mentors and, leveraging our network, because we've got now more than 800 students who are in those positions and a wide variety of positions of leadership who've got advanced degrees. So take advantage of those networks and also have those conversations. And being courageous and speaking up when, with your understanding of who you are and what you know, and staying connected to the Leadership Alliance. So, okay, we have 4 minutes, and there's a couple of questions that's coming in that's more on the lines of advice for students. And because one question is that, I mentioned you got your BA in economics, and then you went to medicine. And so how did you make that switch? What advice would you give to students who are interested in a variety of disciplines?
Yep.
Yeah, so if you could talk a little bit about that.
Yeah, what I would say is be willing to chart your own path.
Yeah.
You know, there's a standard path of medicine, which is like in college, you do biology or chemistry, you're pre-med. I mean, I was pre-med, but then you go on to medical school, and that's fine. It's a great path. Majority of people follow that path, and if you're interested in that. But if you love anthropology, you love history, you love economics, do that. Now, here's one piece of hard advice, which is it's going to be tempting for people to say, if you follow your own path, it's going to be harder. Like, I'm going to be very honest with you, follow your own path, not the tried and true path. It'll be a little bit harder, but it's going to be worth it in the long run because it's going to sustain you. And so you absolutely, some of the most successful people I have seen in medicine, in public health, in almost every field, are people who did it a little bit differently. Because that extra effort that it takes to kind of carve your own path teaches you a lot. And actually, when as you go through it, makes you much, much better at what you do. I think my economics training made me better as a physician. And then when I finished training and decided to start doing research in public health, all that economics training ended up being really helpful in helping me think about and understand the world. So what I would say is, it's going to be a bit of a harder path. I'm not going to lie to you, but if you want to do it a bit untraditional, you should absolutely do that. And it also is, I mean, you're all really young and you have lots of time, but it's never too late to even make changes. I've seen people in their 30s, 40s who decide, I want to go to medical school. And then they do. And that's great. And they do fabulous things. So don't think and don't let anyone tell you that there's a clock and a timeline and you got to do it by X or Y day. Do it when you're ready to do it, and then jump in all the way.
Carve your own path. I think that's excellent advice to leave on. So thank you so much, Ashish, for taking the time, for sharing your thoughts. This has been a wonderful conversation, and we really appreciate you for that. We know how busy you are, so thank you.
Oh, yeah. I just want to say it was my pleasure. Thank you so much for having me here.
Yeah, no, it was great. And our conversations are going to continue in the next 2 days with the symposium. And so our colleagues have posted the link to the website for more information. So we thank you all for participating and invite you to continue to join us. We will have the storytellers tomorrow with Dr. Thais Bingham-Hickman moderating, and then we're going to start delving into the student presentations. So, and then on the day 3, we will have Dr. Camille Burge, and then again, we'll continue with the presentations. Everyone, thank you. Have a wonderful evening and take care. We'll see you tomorrow.